Hello everyone. So my name is Frédéric Michard. I'm from Lausanne in Switzerland. So before I start, I'd like to briefly disclose the fact that I'm today leading a consulting and a research company based in the Swiss Silicon Valley, and where we focus on digital innovations with medical applications. So clearly, artificial intelligence, big data, and machine learning are buzzwords. But what do they really mean, particularly for anesthesiologists and intensivists? So big data speaks for itself. It means we are able today to collect a very large number of data from our patients. It goes from clinical information to lab results, images, and even physiologic waveforms. And so we have the opportunity to analyze this data all together. To do so, we need computer power, and today we have it. We also need smart software, and machine learning systems are actually algorithms we can train to recognize specific patterns or specific phenotypes or signatures, if you prefer, of clinical adverse events of disease states. So machine learning is a field of artificial intelligence, and deep learning, and I will show you a few studies done with deep learning methods in my presentation, is part of machine learning. Besides the classical regression analysis, machine learning techniques include cluster analysis, include artificial neural networks, and random forest of decision trees. But honestly, I think as clinicians, we don't need to fully understand how it works. There are computer engineers, software engineers who do that very well. And I think our responsibility is simply to assess the potential clinical value of these innovations. The first clinical application is the detection of abnormalities. And you will see that main applications developed so far are mainly in the field of imaging. So this is the example of a CT scan from a patient with ARDS. And just looking at the images, it's difficult to say if it's related to a CAP, to influenza, or to a COVID-19. This is here the example of an artificial intelligence system which has been developed to detect or to diagnose COVID-19 directly from CT scan images. So as you can see, they actually used a cluster analysis, and you can actually visualize the fact that the algorithm was pretty accurate. So in red, you have the COVID-19 cases, and you see there is almost no overlap between the different clusters. So the algorithm was able to discriminate pretty well between the different possible diagnoses. Artificial intelligence may be useful for echocardiography as well. As anesthesiologists or intensivists, we use more and more echo devices, ultrasound devices. It's much easier than in the past. Some of us even have a probe in their pocket. They can connect to a tablet or even simply to a smartphone. We also have useful and smart software which has been developed, helping us to measure almost automatically variables like the VTI or the IVC variation, or also to detect and quantify B lines in patients with pulmonary edema. But thanks to artificial intelligence, we can easily imagine to push a bit further the envelope. And this is the example of machine learning algorithm, which has been developed to assess the left ventricular ejection fraction automatically without even measuring the ventricular volumes. So on the left side of the slide, you see the measurements done by the machine learning system. On the right side, you have the measurements done by the clinicians. And you see that actually the machine learning system was measuring the ejection fraction at least as well as clinicians were. Of course, the machine learning system needed just a couple of seconds to give you the measurements. Obviously, it took a bit more time for the clinicians to give the information. So the main advantages of this technique so far, I could be summarized as follows. Expert level interpretation by non-experts. It's available anywhere, anytime. It's obviously quicker than human interpretation. Think about the time a radiologist needs to look at all the images from the CT scan. And sometimes actually these techniques show us what is definitely invisible to the human eye. And I have in mind this now very famous study published in the Lancet last year. It's a machine learning system that was developed to detect past AFib episodes, just analyzing sinus rhythm ECGs. So very impressive and obviously very promising, what is obviously possible with machine learning systems. The other side of machine learning is predictive analytics, or the science of prediction. The idea is to forecast clinical deterioration before it becomes overt. So for instance, we can predict ICU deaths. And this is an example of now also very famous paper in the Lancet Respiratory Medicine by Romain Piraccio, where they tested a new machine learning system to predict mortality and compare the predictive value to more classical scores, for instance, the SOFA, the SAPS-2 of the Apache score, and were able to show the algorithm outperformed existing scores. Having said that, a difference to be a difference must make a difference, you know the saying. And I think Romain is the first to acknowledge that if the difference between the Apache score and the new super learner algorithm was statistically significant in terms of area under the curve, the difference was maybe not clinically relevant. Another study, this time from the team of Maxime Canesson from UCLA, they developed a deep learning algorithm to predict post-operative mortality. It was published in Anesthesiology a couple of years ago. And the predictive value was better than what we get from the ASS score. However, it was not as good as what we can easily obtain from the risk stratification index that was developed more than 10 years ago by Dan Sessler using classical logistic regression and administrative data. Sepsis. That would be really cool to be able to predict sepsis, because we know that the earlier we start antibiotics, the better the outcome. So this is a study where they try to predict sepsis in ICU patients using 65 variables coming mainly from the EMR. They said the minimum sensitivity we can accept is 85%. So for a sensitivity of 85%, the specificity was only 67%, meaning 33% false positive. Another potential very interesting application is the prediction of clinical deterioration on the wards. That would be very useful to know who are the patients who will finally be admitted in the ICU, who are the patients who may crash in the middle of the night. And so that's the concept of, as soon as patients are admitted at the hospital, in tomorrow we'll gather information, integrate information, use predictive analytics to identify patients at high risk of clinical deterioration, and then maybe to upgrade the way we monitor these patients. We would probably propose wireless wearables for continuous monitoring of vital signs in these patients. So this is the example of a score predicting clinical deterioration on the wards, the eCart, developed by the team of Dana Edelson. It's a fusion of age, vital signs, and lab data from the EMR. And in these studies, they very nicely showed that it's a pretty good predictor of clinical deterioration. But again, you see that actually just with the news or the muse, which are easily calculated by the nurse at the bedside, we also predict pretty well clinical deterioration. So you see a bit of disappointment so far with predictive analytics. In addition, there are pitfalls we need to avoid. The first one is to believe that everything is predictable. And here I will simply quote Jonathan Chen and Stephen Ash in this beautiful article I really invite you to read, published in the New England Journal of Medicine. They wrote that no amount of algorithmic finesse or computer power can squeeze out information that is not present. And I think it's nicely illustrated by this recent tweet you may have seen about GoogleX. They were trying to discover a marker for depression or anxiety in brainwaves, but it fell short, probably because actually brainwaves do not contain the information they were looking for. Another pitfall is the quality of the data we analyze. And poor data quality is clearly one of the major factors holding up the big data revolution in healthcare. This is a concept of garbage in and garbage out. Obviously, you may have the best predictive algorithm on the planet. If you feed it with wrong data, with artifacts, you may end up with wrong predictions. The third pitfall is to believe that predicting is preventing. I think the best example is weather forecast. I can tell you what will be the weather tomorrow, but there is absolutely nothing I can do about that. I cannot change it. So this is an illustration. This is the new hypertension predictive index that was recently developed to predict hypertension during surgery. And this is a randomized controlled trial with over 200 patients that was recently published by the team of Dan Sessler from the Cleveland Clinic. So a group of patients, for a group of patients, anesthesiologists had access to this hypertension probability index, and the other group was treated business as usual. And they were expecting a reduction in hypertension in the group treated with the Predictive Analytics software. But they did not observe any difference, no difference in terms of duration or depth of hypertension. So you see, they were able to predict hypertension, but not to prevent hypertension. So in the paper, they discuss what could be the reason for that and acknowledge that actually many clinicians who had access, despite the fact they had access to the predictive information, they did not really change their behavior. And I think it's hard to blame them because today we don't really know how to treat probabilities. Do you? So I mentioned 3 pitfalls. Well, I think there are the fourth one we need to mention, which is specific to what we do in acute care settings, specific to the OR, specific to the ICU. There is no really steady state in our patients, right? There is always something happening or something that may interfere with the clinical trajectory of our patients. So we may have a good predictive algorithm, and the prediction may be no adverse event. But then, because of a iatrogenic intervention or a complication, I mean, the trajectory may be modified. It could be the surgeon, an injury to a big vessel during surgery. That was not predicted. In contrast, the prediction may be poor outcome, adverse events, a severe patient with COVID-19, very severe hypoxemia. And then you decide to use prone positioning to initiate ECMO. And then you will change the clinical trajectory. So I think that on the words, probably predictive analytics will or should help us much more than in very acute care settings where there are many confounding variables that are susceptible to modify the predicted trajectory. So in conclusion, as of today, the application of AI remains limited, particularly in anesthesia and critical care. The main applications are for diagnostic with imaging techniques. Predictive analytics has potential as well, particularly on the wards, but you saw there are challenges ahead. And I'm not sure we are ready to treat probabilities. At least we need to clarify this issue if you want to envision to use predictive analytics to guide therapeutic options, therapeutic decision in the future. This is a very hot topic. This is hype, so the number of innovations and publications will definitely continue to grow at a fast pace. And before closing this presentation, I want to share with you this painting. I don't know if you know it. It was sold a pretty good price by Christie's a few years ago. And it was done by it was created by an algorithm, a machine learning algorithm that was fed with a large number of famous portraits you could find in museums. And then at some point, a computer has been asked to do one, and that's what it did. So I don't know if you like it, but personally, when I saw it, I thought about this book, Artificial Intelligence, Unintelligence. So as clinicians, we need to stay away from novelty blindness and carefully investigate the potential clinical usefulness of innovations before adapting them in our practice. With that, I thank you very much for your attention.